Today I will discuss on acute mastoiditis, definition, etiology, clinical manifestation, and the treatment. Acute mastoiditis is a suppurative infection of the mastoid air cells with symptoms of less than 1 month's duration. The most common risk factors for mastoiditis include acute otitis media that was not treated or partially treated with antibiotics, cholesteatoma, and immunodeficiency. Common pathogens include strep pneumonia, Group A Streptococcus, and Staph aureus. But for those with recurrent acute otitis media, you would have to consider Pseudomonas aeruginosa. Acute mastoiditis presents as a post-auricular inflammation, erythema, edema, tenderness, and fluctuance on physical examination, and a protruding auricle, and also external auditory canal edema. Signs of acute otitis media include fever, discharge, ear pain, and irritability. Most of the time, acute mastoiditis follows acute otitis media if it is partially treated. So the signs and symptoms might overlap. When we see potential complications, meningitis, intracranial abscess, venous sinus thrombosis, facial nerve paralysis, permanent hearing loss due to damage of inner ear structure, osteomyelitis, basal abscess or neck abscess beneath the sternocleidomastoid and the digastric muscles. Management of acute mastoiditis is first, it is a so painful condition, so analgesia is needed, and all cases require antibiotics. All cases requires antibiotics. Most need IV antibiotics and admission. Most severe cases with complication might require mastoidectomy or surgical resection of mastoid cells. Indication for imaging contrast CT include features suggestive of complications such as retroorbital pain, meningismus, cranial nerve deficits, focal neurology deficit, and altered consciousness. And also, if the child is severely sick or toxic appeal, we should have to do contrast CT scan to check for potential complications that we have mentioned above. Antibiotics in mastoiditis include the first line is ceftriaxone with metronidazole. This should be IV and for 10 to 14 days. And if the patient is having IG-mediated penicillin allergy, ciprofloxacin, metronidazole, and vancomycin for 10 to 14 days is given. And when the patient improves, consider early IV or PO switch. Once improving, to complete 10 to 40 days course with amoxiclavulan or augmentin. If associated with venous sinus thrombosis, this will require a minimum of 4-week antibiotic treatment, 2 weeks IV and 2 weeks PO.